But among the things that happens is very small arteries that don't really have, the small capillaries that don't have any muscles, they swell to slow down the blood in the hope of extracting more oxygen. But what that does is it creates a greater resistance of the blood through the beds and actually higher viscosity of the blood and sluggishness, etc. And you know, this is not so much a linear process as a very complex process of problems, because then you have to produce energy through non-aerobic pathways that make more lactic acid and create more acidity, and it's kind of not such a great thing. So some of the things that typically reduce the partial pressure of arterial oxygen are things like a loss of elasticity of the tissues in the lung, so that the expansion of the lung isn't as great, which is very typical with the aging process. A process called shunting, where let's say the pulmonary venous blood, the blood coming into the lung, or the venous blood coming into the lung goes right, doesn't get oxygenated at all. It just goes right into the heart, and so it never so that happens in diseased patches of lung tissue. Or there could be what's called ventilation perfusion mismatches, where again, as with certain types of pulmonary disease, the vessels can go through, but the area of the lung the vessels are going through doesn't receive oxygen or isn't aerated appropriately. For instance, if there's a big bullous or a loss of alveolar integrity, if you would, or if there's a collapse of areas of lung tissue, etc. But these things happen in very big and dramatic ways in acutely ill people in the hospital, but in very small and incremental ways as we get older or are chronically ill. So it's not an either-or phenomenon. and then you can have a reduction in the partial pressure of oxygen with a reduction in the force of the heart contraction, cardiac output. You could have, and there's several other common possibilities. And then on the venous side, you could have an increase in venous oxygen, which is undesirable, because of, let's say, poisoning of the mitochondria, so they're not as efficient at making energy and utilizing the oxygen. And that injury or poisoning could come from acute toxicity, chronic toxicity, infectious processes, drugs, etc., etc. So Van Arden made the observation over time that if you gave people a stepped process for an improvement in tissue oxygenation, not only was there an improvement at the time of the therapy event, but with time the improvement was sustained, and sustained for very extended periods of time. Again, the length of the benefit is a function of the health of the individual, their re-exposure to whatever intercurrent stressors might be affecting them, and I guess just normatively in time and their age. So the older the person, the less the sustained benefit. So the first step was to improve flow. And to that end, back in the 1950s and 60s, he was using dipyridamole, which is a medicine we use now to decrease the stickiness of the blood and to actually create a little vasodilatation. And he was using a dose of 75 milligrams. He was using magnesium orotate, which in those days was, they thought highly of it because they thought somehow that combination was very biologically active in their laboratories. it's hard to get magnesium orotate. And it's not absolutely even clear to me that magnesium orotate is better than, let's say, magnesium glycinate or any other type of magnesium. Because when we give people like a Myers cocktail and IV magnesium push, they get a flush, you know, and so we know magnesium works if you get it into the body adequately. But they were only using 100 milligrams of magnesium orotate, which is only about, I think, 30 milligrams of magnesium, if I'm not mistaken. And they were just using 30 milligrams of thiamine, vitamin B1. But again, these were the people who were the primary scientists at a very exciting time of discovery of mitochondrial function and whatnot, and they really were pretty sophisticated people. And they would administer these three products 30 minutes before the exercise session. And then the second part of the oxygen step therapy would be to oxygenate the body. And they were using various amounts of oxygen, depending upon the magnitude of the person's illness, their disability, their frailty, and I'll discuss that later. But what we've been doing in the there's a quick therapy version, which for most of our patients seems quite adequate, is 100%, we use a rebreather mask with 10 liters per minute of oxygen, which is essentially 100% oxygen. Now, in the air you breathe, assuming that the world stays as it is, and of course the amount of oxygen in the air is actually declining according to some scientists, I think, but it's about 20% of the air you breathe is oxygen. So we're giving 100% oxygen. And the third part of the oxygen step therapy is the exercise part. So we have people, you could do it on a bicycle, you could do it on a treadmill, you could do it on an elliptical, you could, because the point of it is to increase blood flow to the periphery and throughout the body, increase cardiac output. And the heart rate at which a person exercises is ideally a heart rate which we established with the cardiopulmonary stress testing. It's a heart rate that doesn't that's been demonstrated for that individual not to produce too much lactic acid, because you're giving them 100% oxygen. If you give them if you make them as the inference from the production of too much lactic acid is that you're creating really an excess of free radicals. So the oxygen plus the free radicals isn't so good. So they're typically exercising at a very modest heart rate. And with time, individuals, if they're retested, would need a higher heart rate, but be that as it may. And then the frequency with which we do it to get the best results is 3 times a week. I mean, I know people have a tough time with it, but it's 3 times a week. And the length and duration is a function of the health of the individual. Could be as short, in my mind, as 4 weeks, or as long as 3 months. And typically what we'll do is we'll repeat the oxygenation study, where we do the transcutaneous arterial oxygen measurement, and we do the venous oxygen measurement. That isn't covered by insurance, and we charge, I think, $65 for that test. And to do the oxygen step therapy, we charge $60 a month. So that I've tried to keep the price low, because I think it's a really wonderful concept in promoting health. And so it's not a big money maker, but it is a lot of fun. Yes?
A couple of things. Another vasodilator is L-Citrulline.
Yes.
It increases nitric oxide. And also, you were talking about the acid-alkaline balance. You want your urine to be acidic to kill bacteria.
Right.
And there's buffers in the blood that stay, it can leach calcium and stuff from your bones, but there's buffers in your blood that takes care of the acid-alkaline balance.
That's true when you're healthy. And I'll get to that in a second. So typically what we'll do is we'll remeasure we'll redo the oxygenation test to see if in fact the person's showing progress. And if they're not, we might make adjustments.